Hello, Dr. Debbie Morris here, and this is lecture 2 of the neurology course. We are going to go over material that we did in history and physical exam in the first semester and talk about the neurological examination, and in a little bit more detail in some cases than we did then. This lecture is based on material that was initially put together by Dr. Brunilda Cordero, who used to teach this course, and was modified and added to by Dr. Scott Fisher, and then redone by me. So there are a lot of people who've contributed. And we have a number of lecture objectives that involve essentially going through the neurological exam and the tools that we use and what the elements of the neuro exam are, recognizing that when you do a neurological exam, you're not always going to be doing all of these things. In fact, you're rarely, if ever, going to be doing all of these things. And it depends on the presentation, how quick and casual or how slowly and thoroughly you do your neuro exam. But we'll talk about more details, as I mentioned. Thinking about when we are testing, what we are testing anatomically. So that's what I'm talking about here, how the exam pertains to the structure of the nervous system. We're also going to talk a little bit about coma and how we assess neurological function in patients who aren't able to cooperate with us, and how we assess the Glasgow Coma Scale score. So there are a few reasons why we perform neurological examinations. The main one being to assess symptoms that are brought to us by a patient in order to identify potential diseases and disorders that occur in the central and peripheral nervous system. We use various elements of the neuro exam to localize the source of neurological symptoms, using maps and tools like the dermatome map, myotome maps, using reflexes. All of these things can help us figure out where a lesion is, assessing whether it's a central or a peripheral problem, and again, peripheral sensory and motor distribution. And then in the case of coma, the Glasgow Coma Scale and some of the tests that we do to assess neurological function can help us estimate prognosis, have an idea how the patient is going to do. There's some tools that we routinely use during a neurological exam. Everybody needs a reflex hammer. This is just one example of a reflex hammer, not a great one. It needs to have enough weight or heft to be effective. It ideally has a handle which makes it easy to pivot or swing, as I've talked about before and will demonstrate again. We should have some way to assess sensation to pain, which is pinprick, something like a safety pin or a broken wooden swab, to look to assess pain and to assess light or crude touch, which are different sensory modalities. We need a tuning fork. This one says 256, but I think the tuning fork is a 512. But you need one of the ones that is lower hertz, so 128 or 256, and those are the ones that have the weighted ends. We use them to test for vibration sense. We use them to do the Weber and Rene test to determine whether a patient's hearing loss is conductive or sensory neural. And some people use their tuning fork when they're assessing temperature sensation, which I'm not even going to talk about because it is so rarely done. Sorry, I'm having trouble getting to my next slide. Okay. The ophthalmoscope, and this is what we call a direct ophthalmoscope, is a very important tool in our neurological exam, and we use it to directly assess the health of the second cranial nerve, of the optic nerve, the optic disc. We can look at the fovea, at the vessels of the retina, assess retinal health, whether there's damage from conditions like hypertension or diabetes, whether there are other retinal damage like retinal tears and detachments. And it can also be used to assess pupillary light response. You don't need a separate pen light, but you can have a separate pen light, or you can use the otoscope, but it is a light to shine in the pupil to assess pupillary light response. Most of us find a visual acuity card helpful, and some visual acuity cards also have a pupil diameter reference on them, so that can be helpful. I like to use cotton swabs, not for testing corneal reflex. We'll talk about corneal reflex, but it's rarely done and really never in a primary care setting. But a cotton swab is a great way to test what we call light touch or crude touch. In addition, a wooden cotton swab, broken, you can use the broken wooden end to assess pain or sharp touch or pinprick sensation. If you're going to assess the first cranial nerve, having something with a very familiar smell can be helpful, but I'm going to tell you the truth, nobody really does it. If you're doing a thorough cranial nerve exam, you might want to have something like a bar of soap with a scent like rose or orange that everybody recognizes. When I was growing up, they had us carry vanilla extract and coffee or things like that, but this is not something you're likely to do. Could you try again? Here, Siri's interested in what we're doing, talking to me.
Is there something else I can help with?
Stop.
Done.
Okay. Sorry, I was talking to Siri. You may or may not have heard Siri. The neurological exam starts with just our observations, looking at things like whether the patient is awake and alert, if they're responding to us, their general appearance in terms of things like hygiene and dress. Somebody who looks like they are very rumpled and poorly groomed compared to somebody who is well put together. These things are part of our general observations that are helpful. We look at their posture, at their movement, so their motor activity, and whether there are involuntary motions, things like tremors and other unusual involuntary motions, and also things like restlessness. You see some people who are moving like jittery and constantly moving. There are a lot of potential involuntary movements that can give us clues as to a patient's neurological status. There's something called chorea, which are these sudden ballistic movements that occur in certain serious neurological conditions like Huntington disease. Athetosis, which are writhing, repetitive movements. Occasionally we see a muscle group in which the little bundles of muscle are independently twitching, and this tends to occur in muscles that have been denervated, in other words, lower motor neuron injury. Occasionally you'll see it in the tongue. Dystonias are a number of different involuntary movements that are tonic, sudden contractions of the muscles of the neck, which is torticollis, of the tongue, of the back. And this illustration here is an illustration of a tonic contraction of the back and neck extensors called opisthotonus. And sometimes people have abnormal movements of their mouth and eyes. So the relevance of those movements, probably the most common, among the more common involuntary movements that you'll see are evidence of tardive dyskinesia, which can be an adverse effect of a number of drugs, particularly antipsychotic drugs. And you'll see these people involuntarily smacking their lips, maybe chewing, maybe grinding their teeth, various other unusual facial movements that are repetitive. In folks with Parkinson-like symptoms and Parkinson's disease, where there is damage to the substantia nigra and the dopamine-producing cells there, you may see a resting tremor. And in Parkinson's, as we'll talk about in several weeks, there is a very specific tremor that is common. People who have cerebellar damage may also have a tremor, but these tend to be tremors that get worse with motion, so they're called action tremors or intention tremors or volitional tremors. And as the limb moves and attempts to perform an activity, the tremor gets worse. Vital signs are, of course, part of every patient assessment that we do. Pain scale has become a vital sign and part of that essential assessment. But the reason we're mentioning vital signs here is that in people who present with a high fever and headache and suggestions of possible meningitis or meningeal irritation, like a stiff neck and a headache, then we do a couple tests for something called meningismus. And so here we have an illustration of some of the signs and symptoms of meningitis. And the two tests that are done to check for meningismus include something called the Brudzinski sign and the Koenig sign. In the Brudzinski sign, we flex the patient's neck. And here we're showing a child because many of the times when you're suspecting meningitis, it's going to be in a kid with a high fever. When we passively flex the child's neck, the child is going to flex their knees and hips, or the patient will flex their knees and hips to relieve the stretch on the meninges in the spine caused by our flexion of the neck. In Koenig sign, when we flex the hip to 90 degrees and then extend the knee, there's resistance to extending the knee because of the meningeal irritation, irritation of the dura surrounding the spinal cord. In all cases, and this is all cases, every patient that we see, one of the things that we're looking at is their mental status. Now, you can simply informally assess mental status. If somebody seems to have their mental status intact, they are oriented, their speech is normal, their cognition seems normal, there are no obvious problems with their memory, you've done a mental status assessment. But in terms of the neurological exam, we often do more formal mental status testing using a combination of observing and asking the patient to do specific tasks to assess their memory, their thinking, their language, things like mood and affect, their fund of knowledge. We can also assess mental status using one of the tools that we talked about during H&P1, like the mini mental status examination, the Montreal cognitive assessment, or the mini cog. The mini cog is a very minimal screening test, but these can be used as part of a neurological exam to assess mental status. After that initial assessment of mental status, we're going to move on to the cranial nerve exam, remembering a little bit about what we discussed in H&P1 and also in physiology, and last week in the lecture on neuroanatomy, that the cranial nerves originate largely from the brainstem, with the exception of the olfactory nerve, the optic nerve, and the accessory nerve, and that they have, again, this is, you just got to remember what they are. This is one of the times, I'm not big on telling people to memorize things, but you just have to memorize the names, the numbers, and the functions of the cranial nerves, because this is crucial information to anybody practicing medicine. Remembering that those cranial nerve nuclei may have only sensory function, only motor function, or both. And in this chart, we talk about the specific functions and neuron types of all 12 cranial nerves. So the olfactory nerve is solely sensory. It has no motor function. The optic nerve, the same, solely sensory. Those nerves that move the eyeballs, 3, 4, and 6, the oculomotor, trochlear, and abducens, are solely motor. That's all they do, is they send, they have motor neurons that send efferent signals. 3, not only to the muscles of eye motion, but also, as you remember, to the upper lid, and 3 has some involvement with the pupillary reflex. 5, the trigeminal nerve, which is primarily a sensory nerve, has both sensory and motor involvement. From the sensory perspective, it is the nerve that provides sensation to the face and to the cornea. It also has motor neurons that send efferent signals to the muscles of mastication, so the chewing muscles. 7, which is the facial nerve, has both motor and sensory functions, but primarily the motor signals to the muscles of the face and facial movement and facial expression. It also, however, has some sensory involvement in taste for the anterior 2/3 of the tongue. So we'll go through all of these again. The vestibular cochlear nerve, which there says 7, but it's 8. I'm sorry, I didn't see that, and I'll fix that. Provides sensory input to the central nervous system for the sensations of hearing and of balance from the balance organs. 9 has both sensory and motor input for the sensation of taste for the posterior third of the tongue and the gag reflex. The vagus nerve is both sensory and motor, primarily motor. The spinal accessory nerve, or 11, is solely motor, and the hypoglossal nerve is solely motor. So how do we assess cranial nerve 1? Well, to be honest, we don't. But if we wanted to assess cranial nerve 1, before checking for the sensation of smell, we would have to check for nasal patency, because if somebody can't breathe through a nostril, they're not going to smell anything. If as far as I go in assessing cranial nerve 1, and it is of importance, particularly in the era of COVID, is to ask people if they've noticed any unusual problems with their sense of smell, or changes to their sense of smell. If then you wanted to assess more carefully, you would ask them to close their eyes, occlude one nostril, and then put that familiar smell near the other nostril and ask the patient to identify it. And obviously do both nostrils, maybe with different smells. For cranial nerve 2, or the optic nerve, we do a bunch of things. So assessing visual acuity using the pocket Snellen chart, checking each eye separately and both together, and then assessing visual fields, again, in each eye and in all 4 quadrants, and then using an ophthalmoscope to visualize the optic nerve in each eye, where you're directly looking at the optic nerve, at the optic disc. In addition, you're going to check the pupillary reflex and the accommodation reflex, which involve both cranial nerves 2 and cranial nerve 3, the oculomotor nerve, which is what I was mentioning earlier. So you observe the diameter of the pupils, you observe pupillary symmetry, and then you check each eye for direct pupillary constriction and consensual light responses. So you shine the light into the eye, looking into that eye. You shine the light into that eye, looking at the other eye, and then you switch. In this slide, I'm showing you a couple of images showing clinical relevance. When people have drooping of the upper eyelid, it generally represents a lesion in the 3rd cranial nerve, and in some cases is associated with Horner syndrome. So the ptosis, along with a lack of sweating and a difference in pupil size. And in the lower slide, we're seeing anisocoria, where one pupil is larger than the other, which could be a cranial nerve 2 or cranial nerve 3 lesion, with either a lack of signals, efferent or afferent signals being transmitted. Some people have, many people have a little bit of anisocoria, and it's one of those important things to know about athletes, whether they have a difference in pupillary size prior to play, so that if they do have a head injury, we know whether that is old or new. We check cranial nerves 3, 4, and 6 with our H motion, looking at the movements of the muscles that move the eye. And again, they all have only motor function. When people have problems with this, they they will often have double vision when they are looking in the direction of their palsy because the eyes quit tracking together. There are different lesions in the central nervous system that, when damaged, can result in problems with gaze palsy. And it can actually be in the cranial nerve nuclei themselves, in the brainstem, or in areas of the cortex that are important to generating eye movement. The trigeminal nerve, again, is primarily sensory, so facial sensation and corneal reflex are sensory, and movement of the jaw. We assess the face for sensation, usually with just light touch, but again, we could do the same thing that we do when we're talking about other kinds of sensation, checking for light or dull, or sharp or dull, I'm sorry, and having the patient close their eyes as we assess in both sides of the face and the three regions. We palpate the masseter muscles as the patient clenches their jaw, and then have them open their mouth against resistance. We rarely, if ever, check the corneal reflex, but when done, the corneal sensation is a function of the fifth cranial nerve. Okay, that was sort of meta. Um, Cranial nerve 8 is the vestibular cochlear nerve and is bringing in information about hearing and balance. So we assess hearing, as we've talked about before, with a whisper test or with just rubbing the fingers behind the ear and asking people if they hear the sound. When you determine that there's a hearing abnormality, you can perform the Rene and Weber tests. Again, rarely done in primary care, time consuming, not particularly reliable, but it is something that shows up on tests, so it's something we should know about. We look at cranial nerves 9 and 10 together because they're involved in movement of the soft palate and the gag reflex on swallowing. So it's helpful to just ask the patient if they're having any swallowing difficulties and to have them swallow. Have them then open their mouth wide, stick out their tongue, and say ah as you watch the soft palate and the uvula. And the soft palate should rise symmetrically, and the uvula should remain midline, and you should see constriction of the pharynx in the middle. We used to commonly test the gag reflex, but if there's no need to do that if the soft palate is moving appropriately. Cranial nerve 11, you may remember from the neuroanatomy lecture, while we call it a cranial nerve, is actually a spinal nerve or spinal nerve branches that ascend through the foramen magnum and then seem to be a cranial nerve. And they govern movement of the neck and shoulders, so we have the patient turn their head to each side against resistance and shrug against resistance. Cranial nerve 12, or the hypoglossal nerve, has primarily motor, well, it has entirely motor functions governing the movement of the tongue. So having the person stick their tongue out and move it side to side or against their cheek with some resistance is helpful for assessing cranial nerve 12. So that's the cranial nerves, which is a big part of the neurological exam and can be done really very quickly in just a minute or two, even though we just talked about it for 15 minutes. The motor system evaluation, part of it is just observation. You're paying attention to how the patient positions themselves, to whether or not they have obvious involuntary muscles, but then we check muscle tone and strength. When we're checking muscle strength, we use this scale from 0 to 5, 0 being a muscle that the patient is unable to move voluntarily at all, and 5 being normal strength, which is that the patient can move against your resistance, overcoming your resistance. So obviously you don't put all your strength into it, but you resist movement and the patient is able to break that resistance. And normal is 5 out of 5. We've talked before about the difference between lesions in upper motor neurons and lower motor neurons. Upper motor neurons are the neurons that generate the signals in the brain. Lower motor neurons involve injuries at the level of the motor neuron that actually is sending the axon out to the muscle. And upper motor neurons tend to be characterized, upper motor neuron lesions tend to be often brain lesions, and they are characterized by weakness. And once time has passed after the initial lesion, These are the folks who will have spasticity. They will have hyperactive reflexes, and they may, if it involves lower extremities, have a positive Babinski sign or a plantar reflex with an upgoing big toe. People with lower motor neuron injuries also have weakness, but instead of being spastic, they'll be hypotonic, they'll be floppy. And instead of having hyperactive reflexes, they'll have hyporeflexia. Their muscles will atrophy, and you may see the fasciculations we talked about, just individual little muscle groups, randomly kind of bag of worms squiggling in a muscle. We do strength testing in the upper extremities and the lower extremities, comparing the strength from side to side. And this is a discussion of the spinal myotomes of the upper extremity motor groups. So the deltoid muscle is innervated by C5, the biceps by C6, the triceps by C7, finger flexion by C8, and finger abduction by T1. So chicken wings for deltoid, flexion for biceps, extension for triceps, grip for finger flexion, and finger abduction to check the interosseous and T1 muscles. There's something called pronator drift, which is a way of assessing upper extremity weakness that's somewhat subtle. You have the patient close their eyes, hold their arms outright with the palms up, and then just count to 10. You count to 10 in your head slowly. And when there is a subtle upper extremity weakness, the affected arm will pronate and fall below the level of the other arm. The patient's not aware of this, and it is an indicator of an upper motor neuron weakness. For lower motor extremity testing, we check hip flexion, hip extension, knee flexion, knee extension, ankle dorsiflexion, ankle plantar flexion, and if you want first metatarsal extension, since you're checking L5 with hip extension and knee flexion, you don't have to do first metatarsal extension. There's a video there of the neurologist. He's in lots of my videos, but doing lower extremity strength testing. When we're testing for the sensory exam, we're going to check for pain sensation and light touch sensation. We may check for position and vibration sense, and we may check things like stereognosia and graphesthesia. To check sensation, the best thing to do is to have your patient close their eyes and illustrate for them that this is dull and this is sharp. Can you tell the difference? And obviously this isn't really sharp. Here, I'm sitting at my sewing area, so I have a pin. I have a dull end and a sharp end. So you might say, close your eyes, this is dull, this is sharp. Can you tell the difference? And then say, now every time I touch you, say sharp or dull. And then varying your pace and your dull or sharp, you check dull, sharp, sharp, dull, dull, and you go through your dermatomes. As I've said several times, I tend to use a broken wooden swab. It may be getting harder to find wooden swabs. Or when I used to be in the office every day, I had a string of safety pins on my coat or on my desk, and I would take a safety pin, bend it open, and use the sharp end and the dull end, and then throw it into the sharps container when I was finished. For position sense, we have the patient close their eyes, hold a distal digit by its sides, and demonstrate up and down, and then ask the patient, is this up or is this down? One of the reasons that we check these different sensory modalities is when we suspect there's an issue, we are trying to sort out whether there's damage in the dorsal column or the spinothalamic tract. I am not going to ask you to remember those specifics, but if you ever end up in neurology, you may need to. So fine touch and position, sense, and vibration are conducted, taken to the central nervous system through the dorsal columns of the spinal cord, and just dull touch, temperature, and pain are conducted by the spinothalamic tract. If somebody is numb and they don't seem to have sensation to, say, pain and crude touch, then you might want to check temperature sensation. You might want to check position, sense, and vibration. And if position, sense, and vibration are intact, it suggests that maybe the problem is in the spinothalamic tract and the dorsal columns are intact. Do remember with both position sense and vibration sense that if that sensory modality is intact distally, you can stop. You check at one joint. If you are unable to elicit position sense, proprioception at the great toe, for instance, you can move up to the ankle. If not at the ankle, move up to the knee and just do the same thing, up, down, which is it. Vibration sense we're using, and here they're showing the correct tuning fork. It's a tuning fork that's got the weights on the end, a lower pitch tuning fork. Set vibrating and press to the joint that's being tested, asking the patient if they feel pressure or vibration. And again, if it's absent distally, move to a more proximal joint. Stereognosis is a more complex test that requires sensory processing in the cortex, along with being able to feel the item in the hand. So you give somebody a familiar item, a key or a pen, and with their eyes closed, ask them to identify it. For graphesthesia, we write a number on the patient's hand with their eyes closed and ask them to identify it. Moving on from sensation into reflexes, we talked about a 5-point scale for the motor exam. It's a semi-quantitative scale. People have some differences of opinions for deep tendon reflexes, but there's a 5-point scale here too. Again, it's semi-quantitative. 2 is normal for reflexes. So 2+ is a normal reflex. 3+ is a brisk reflex. 1+ is a low normal or diminished reflex. All of those can be perfectly normal. Some people are just a little jumpier than others. What's important is that it's consistent and specifically that it's symmetric. When there is a very brisk reflex with clonus, we would call that a 4. When there is a reflex that you can't get at all without using the Gendrasik maneuver or another form of reinforcement, you'd call that trace or 0.5. I've never seen anybody say 0.5. And if you can't get any reflex, you'd call it a 0. So this is the scale, semi-quantitative scale that we use for classifying reflexes. We check the biceps reflex by putting our thumb on the biceps tendon and hitting our thumb. And we look for a contraction of the biceps and a flexion of the forearm. The biceps reflex and the brachioradialis reflex are mediated by C5 and C6. We check the triceps reflex by kind of holding the weight of the patient's arm, having them relax and directly striking the triceps tendon and looking for extension of the forearm. And the triceps reflex is primarily mediated by C7. Brachioradialis, we've talked about. I don't have a slide. I should have added one. I apologize. The patellar reflex, we strike the quadriceps tendon with the reflex hammer directly. Notice that he's using the broad side of the reflex hammer, using your wrist motion and swiveling. And the knee jerk is primarily mediated by L3 and L4. There are some abnormalities aside from diminished or increased reflexes. There's something called a pendular knee jerk that can be a result of cerebellar injury, and there's a video here. There's also a 2-minute neuroscience video that you can watch that talks about the patellar reflex arc and the sensory and motor and interneurons that are involved. We elicit the Achilles reflex or the ankle reflex by having the patient relax their foot, kind of maybe holding it up a little bit, and then hitting the Achilles tendon with the broad side of the hammer, feeling for a plantar flexion as you hold the foot. And the ankle reflex is mediated by S1. To check for clonus, we just briskly pull up on the ankle and feel for that repetitive motion, that flexion. And there's a video of clonus, nice video of clonus. We generally check the Babinski or check for a Babinski, which is an abnormal plantar reflex. So using something rigid, we stroke from heel to the big toe along the lateral sole and across the metatarsal heads. And the normal response is for the toes to flex. The abnormal response, which is a sign of upper motor neuron injury after about the age of 1, because Babinski's normal before the age of 1. The abnormal response is for the toes to fan and the big toe to go up. So if you say there's a Babinski, you're saying it's an abnormal reflex. If the plantar reflex is normal, the toes are down going. If you want to be very clear, say plantar reflex, toes down going, or plantar reflex, toes up going. But know which one is abnormal. Leaving reflexes for cerebellar assessment, we check a number of things around coordination and balance. So rapid alternating motions or movements is a good way to check cerebellar function. Having the patient flip their hands rapidly for several seconds. The inability to perform rapid alternating movements is called dysdiadochokinesis. Dysdiadochokinesis. And it is a finding that we see in multiple sclerosis sometimes in adults when the multiple sclerosis is affecting cerebellar white matter. In children, when this happens, worry about a cerebellar tumor. We will often do this test called point to point or finger to nose, and there's a video of my favorite neurologist doing this, having the patient extend their finger, touch their nose, touch your finger, and then move your finger around. And the inability to do that is called dysmetria. You can, for lower extremities, have the patient run their heel down their shin, which is just a test of coordination. It obviously, if the patient has a strength problem and they can't do this test, then you're not checking coordination. Also, people who have lack of proprioception or position sense may have difficulty doing this test. But lack of the ability to do it can suggest a cerebellar lesion. And we certainly want, in terms of checking coordination, to watch the patient walk. So you have them rise from a seated position, walk across the room, just watching their gait, and then walk back in a heel to toe or tandem gait, assessing their ability to stay upright and to perform that motion with coordination. Sometimes we have people walk on their heels or on their toes, which is checking strength of their plantar and dorsiflexors of the ankle. But that's not so much a check of gait as it is of strength. So people who have trouble with tandem gait are having a problem with coordination that might be due to toxicity like ethanol intoxication. With proprioception problems, people with proprioception problems can't do this. People with vertigo or problems with their balance organs or with parts of the cortex that process balance and position can have problems with tandem gait. And people with leg tremors can't do a tandem gait well. And then for a Romberg test, you have the patient put their feet close together but not touching, close their eyes, and make sure that you assure them that if they start to fall, you'll catch them, they'll open their eyes. As we've mentioned before, a Romberg test is kind of nonspecific. So a positive Romberg test might indicate a cerebellar lesion, but it could be a problem with the semicircular canals. It could be a problem with proprioception. There are different possibilities there. And other symptoms and other findings will help you to determine which it is. The end of this lecture, we're going to talk for a little bit about some specific items in the examination of a patient in a coma. When somebody's in a coma, obviously assessing mental status, you can't check their orientation, but you can observe their response to stimuli. So do they open their eyes when you talk? There are some specific visual tests that are done, and you can test response to painful stimulus. So if you press a fingernail hard with something hard like a pen, or do a sternal rub or pinch an earlobe, do they withdraw? Do they grimace? Okay. There are some specific postures that occur in comatose patients. There is a posture that is called a decorticate posture, in which the forearms, wrists, and fingers are flexed with adduction of the upper arms. So, flexion of the upper extremities and extension of the lower extremities. Then there's something called decerebrate posturing, in which the arms move from this flexion position to an extension and pronated position with continued extension of the lower extremities. And when a patient is progressing from a decorticate to a decerebrate posture, that suggests that bad things are happening, like tonsillar herniation. And I think in the notes there, whoops, it says that decorticate posturing is not as bad as decerebrate posturing. Decorticate posturing, those people may recover. People who have decerebrate posturing are doing very poorly indeed. I mentioned visual stimuli. There is a reflex called the doll's eye reflex used in a comatose patient, in which obviously we have to hold the patient's eyes open and we passively turn their head from side to side. The normal response is that the eyes are going to shift away from the direction you're moving the head, so that the eyes appear to be trying to look at the same thing, trying to maintain gaze. A positive doll's eye reflex, the eyes are stationary, moving with the head. And this is something that is done as part of testing for brain death. There is, I'll let you watch this video. I'm not going to add it. Well, here, let's add it. I'm going to let that go because I don't believe they show a patient with actual, with coma and that inability to maintain those involuntary movements. But you saw normal. Whoops. Okay. Calorics, are a test called the oculovestibular reflex, where water that is either slightly, well, somewhat chilled or somewhat warmed is squirted into the ear, causing a involuntary reflex. This is not something you're ever going to do. It is occasionally done in thorough neurological examinations with some very specific conditions. And here is a video that goes into great detail about how to do this testing. You don't have to really watch it because, again, this is not something you're ever going to do. We try to test motor function in comatose patients. We can check reflexes. We can check tone by feeling resistance to movement, to passive movement. We can check withdrawal from noxious stimuli. So if you cause pain, the patient should try to withdraw their limb. And that's obviously the withdrawal is a better sign than lack of any response, which brings us to the Glasgow Coma Scale. So the Glasgow Coma Scale is a way that we use to measure the severity or depth of coma or of head injury. And we assess three things for the Glasgow Coma Scale. We assess eye opening, we assess the best verbal response and the best motor response, and we score it as you will see on the next slide. Patients who have low Glasgow Coma Scales, 3 to 8, are considered to be in coma. And patients with very low Glasgow Coma Scales, like 3 to 4 at their initial assessment, have a very high likelihood of either death or of be ending up in a persistent vegetative state. So what is that score? Well, if people open their eyes spontaneously, they get a 4. If they open their eyes only when you talk to them, they get a 3. If they open their eyes only when you hurt them, they get a 2. And if they just don't open their eyes, no matter what you do, they get a 1. Verbal responses, 5 is oriented to time, person, and place. 4 is confused, so not oriented, may be able to speak. People who are with a 3 are using inappropriate words and maybe having some difficulty with communicating along with being confused. People who speak but the speech is incomprehensible get a 2, and people who don't speak at all get a 1. And then motor responses, a 6 is obeying a command. A 5 is moving with localized pain. A 4 is flexing to withdraw from pain. A 3 is abnormal flexion, like that decorticate posturing that we talked about. And a 2 is abnormal extension, like that decerebrate posturing that we talked about. And 1 is no motor response at all. And we add those 3 things together. So people with a head injury whose GCS is 13 to 15, we call that a mild head injury. If their GCS is 9 to 12, we call it a moderate head injury. And if their GCS is 3 to 8, we call it a severe head injury. And these are people who need to be intubated. So that's our lecture for today. And again, this is here as a resource if it helps you to study, but I hope you enjoyed it. I wish that had